Good morning. I'm the token non-neurosurgeon here, and I've probably heard more about brains today than an orthopedic surgeon has heard in years. So I'm going to sort of dumb things down for the rest of you, and I'm going to just talk about the emergency clinical assessment of the spine. So my objectives are to understand the rationale for rapid spinal assessment in the emergency setting, differentiate the assessment in degenerative trauma, tumor, and infection, and obviously I'm going to focus mainly on trauma because that's the mainstay of this. And we're going to understand the concept and process of, quote, clearing a spine in the trauma setting, because that is something that's probably, particularly at your stage, the biggest thing that you spend a lot of time worrying about. So talk a little bit about that as well. So why do we need to do a rapid assessment of the spine? Well, it's pretty simple. Many spine problems are associated with potential or existent neurologic injury. They either have or they're the potential of developing a neurologic injury. You need to determine that because that's going to guide treatment prognosis and also the speed or rapidity with which you're going to do that. Many pathologies in the spine lead to instability, which can put the neurologic structures at risk. You need to know what those are. And also, many of the neurologic insults that we see are time sensitive. We have a limited amount of time. And the classic example here is the partial spinal cord injury in the trauma setting. These are patients that you want to get treated as soon as possible. So what tools do we have that we can use in the rapid assessment? Well, first we start with a history, physical exam, imaging. Rarely do we get to the point of labs. The one exception to that would be in infection, where that's probably the only case you're going to use labs in the rapid assessment in the trauma department. So the history, you get a surprising amount of information from the history, even in the trauma setting. The first thing, what is their injury? What was their injury? And in the trauma setting, this is the key. What was the mechanism of action and the level of force? And you need to get this information. There is a huge difference when I hear about somebody who has a T9 fracture, when I find out that it is an 80-year-old who tripped and fell, or a high energy trauma, such as my favorite personal story is a gentleman who was struck by a car while crossing a motorway and was found 65 meters from his shoes. So think about the energy that was imparted there. Not only did it hit him fast enough that it knocked him out of his shoes, but it carried him 65 meters away from where his shoes were found. What are their current symptoms? What are they complaining of? Are they complaining of back pain or no pain? Are they complaining of arm pain, leg pain? Are they unable to move? Do they have sensory disturbances? What is their current neurologic status? And you just had a quick assessment, but basically look at power, sensation, reflexes. Has it changed? Find somebody who was on the scene in trauma or in other settings. Has there been a change in their neurologic status, and over what period of time? Past medical history, not really that important in trauma, but very important in the potential for tumor or infection or even degenerative disease. In trauma, the key is you also need to know what are the other injuries. So the physical exam, we went through this, the neuro exam, sensation, motor, reflexes, upper motor neuron signs. So if I'm examining a patient with, say, a central cord syndrome, it's important to know if they have upper motor neuron signs. That tells me that is a person who had symptomatic myelopathy before their recent trauma, because it takes time to develop the upper motor neuron signs after trauma. With central cord syndrome and they have upper motor neuron signs, you know they had a pre-existing myelopathy. You need to do, again, in the trauma setting, a detailed musculoskeletal exam. You've got to look for those other injuries. Chest and abdominal exam is also important in the trauma patients, and I cannot stress this enough. In the trauma patients, you have to roll them over and examine the back of the spine. Palpate the spine, feel for steps or gaps, look, see if there's other injuries that are there. This is one of the classics here that you look for is the lap belt sign. Do we have? Yes, the lap belt sign. So bruising across the abdomen or the hips, highly associated with intra-abdominal trauma, highly associated with flexion distraction type injuries and instability. So you do have to take a look at more than just the spine in these patients. So imaging in the trauma setting now, x-rays, we usually aren't getting them. because most of the trauma patients are going to the CT scanner and being pan scanned, and you'll pick up the injuries and define them better on CT scan. So x-rays really don't have a big role in trauma. They may have they do have more of a role in degenerative tumor infectious pathologies. The key in trauma right now, most of the diagnosis is made by CT scan. Most patients are getting chest, abdomen CTs, and now while they're doing that with helical scanners, basically you scan brain, cervical spine, chest, abdomen, pelvis all at one time. And with new generation scanners, that takes a very brief period of time. Also, the CT scan is very useful in decision making in tumor. MRI overcalls the involvement of vertebral bodies in tumor. CT gives you a much better idea of stability when assessing tumor. MRI is a variable use in trauma. It's not mandatory in all traumas, but we will occasionally use it. It is vital in the diagnosis of tumor and infection. So in the trauma setting, what does clearing the spine mean? Anybody? Somebody tell me what clearing the spine means. That's how you do it, but what does it mean? Sorry. Actually, it doesn't. Clearing the spine does not mean that there is no injury. What it actually means, and it does not mean that there is no need for precautions. What clearing the spine actually means is a thorough assessment of the spine and a determination of what specific precautions are necessary to mobilize and care for the patient. The classic example would be a patient with a stable burst fracture that you feel needs a brace. Once you get them to that point, their spine is cleared. So it doesn't mean there's no injury, and it doesn't mean there's no need for precautions. It means you know what's going on and how to manage it. So how do we clear a spine? So first and easiest, in an awake cooperative patient with no distracting injury, you can clear them clinically by asking them, do they hurt, feeling if they're tender, and getting them to go through a full active range of motion. If they can do all of those things, you can clear them. Now, the key in this and what it all comes down to is, what is a distracting injury? Some people will say that any other painful injury is a distracting injury, and I think that's a little bit of a problem, because if somebody has an ankle fracture, I think you can do an adequate assessment of their thoracic and cervical, or cervical, thoracic, and lumbar spines. I do not consider an ankle fracture to be a distracting injury. I do not consider a wrist fracture to be a distracting injury. What I consider to be a distracting injury is pain in an area that also would correlate so if somebody, I'm worried about lumbar, if they've got a femur fracture, that is enough of an injury because it can overlap pain patterns. And also femur fractures are phenomenally painful. Similarly, a patient with a shoulder fracture, I don't think you can adequately assess a neck in a patient with a shoulder fracture, because as you're moving the neck around, the shoulder is going to hurt. So you need to be a little bit cautious in that. When in doubt, if you think a distracting injury is enough that it's going to alter your exam, assume that the distracting injury is important. And then basically, really simply, any painful area needs imaging. And in most cases, you're going to do all of them. Again, the helical CT scan, the study that people quote, a helical CT scan of the cervical spine is a 90% not negative predictive value of any injury, and no unstable injuries were missed. Thoracic and lumbar were even higher. I put the reference in there. And this is what people use to say that you can clear a spine based on a CT scan. But you will find that every one of us in the audience has at least one patient that they remember where the CT scan was negative and they turned out to have an injury. And in those patients, usually, that's why most of us, if we have the time and the ability, will go on and get an MRI in the patients that we can't otherwise clear. And I've actually even seen patients who had negative CTs and negative MRIs. I've seen one case presented of a patient with negative CT, negative MRI, who did have an unstable injury. So you can never be perfect at it. And so the problem here is in the patient, the obtunded patient in the ICU. At what point do you say, listen, we got to get the collar off of them? Because if you leave a collar on them, eventually they're going to develop pressure ulcers, things like that. And so you have to basically look at evaluating it. One thing that some people will do is they will actually do an examination with fluoroscopy under anesthesia and put them through a traction test, a flexion extension exam. Mitch Harris from Boston has a pretty good case series on that he's published. I have used that occasionally in those patients that we really need to clear them, that we don't see that their neurologic status is going to recover. So when do we need an MRI in trauma? When do we have to get one? Really, in the thoracic and lumbar spine, we probably never need one. Occasionally, it will be useful to assess the posterior ligamentous complex, but in that patient with the burst fracture that you're unsure the involvement of the posterior column and you're unsure whether you want to treat them surgically or non-operatively, one of the options you have is an upright x-ray. And if they do not change significantly their alignment in the upright x-ray, you can probably treat them non-operatively. So I'm not sure how often the MRI adds to my treatment options in the thoracolumbar spine. In cervical spine, the problem, it comes back to this paper by Frank Eismont in 1991, looking at patients with jumped facets. And what Frank Eismont's paper, he had a couple of patients who deteriorated neurologically after closed posterior reduction under general anesthesia. And so the whole question became, the idea that there is the potential for disc displacement in these patients. This was a couple of cases over a long period of time. So we don't even know the denominator here. So we don't know how common this is. But in general, in patients, I think if you're going to do an operative posterior reduction under general anesthesia, you have to have an MRI in that patient before taking them to the operating room. I think that's one clear one where you have to have an MRI. In a neurologically intact patient that you're going to do a reduction on, if they're neurologically intact and you can get one easily, I don't think there's any harm in waiting to get there, to get that, and there is potential valuable information there. So in that case, I would usually opt to get an MRI. If you're planning an awake reduction in a neurologically intact in a cooperative awake patient, I don't think you need an MRI before beginning. In those patients, particularly the ones with partial or complete neurologic deficits, the key in those patients is how quickly can you get them reduced, and getting the MRI is going to take time. And if they're awake, they can give you any neurologic exam. You can get a neurologic exam to see if things are changing. In patients who you're going to do an anterior reduction, you probably don't need it because you're going to do a discectomy on them anyway. And I think that if you've got a patient who is neurologically injured and it's going to take time to get the MRI, I don't generally do it. I move straight to some form of reduction, either be that an anterior or just going ahead with a posterior traction reduction. Okay, moving on now to tumor and infection. I'm going to lump these together. The key to management in the emergent setting in the tumor and infection patients is their neurologic status. Are they neurologically intact? Is their neurologic status changing? And also, in many cases, how long has their neurologic status been out? If you have a tumor patient or an infection patient who has had complete motor paralysis for more than 24 hours, there's probably not much you're going to do with that patient. On the other hand, if you've got somebody who's got a couple of hours of neurologic deterioration, the clock is ticking. You need to address these patients as quickly as possible. The only lab test, I think that C-reactive protein is this is the one lab test I would do in the emergency assessment. It is a good test for presence of infection. It's more responsive than ESR, so that's the one I tend to use. I think in tumor and infection, both CT and MRI are useful. If they have a known history of malignancy with metastasis, if you know this is a patient who has prostate cancer with metastasis, I don't think biopsy is necessary in the urgent management of tumor patients. If the patient is neurologically stable and has no history of tumor, I think the tumor workup is important. Look for other sites, look for primaries, look for other sites to biopsy. Anytime you're in the OR, send pathology. I remember vividly a patient who had a known history of breast cancer with skeletal metastasis. We took her to the OR, we did send pathology. She had multiple myeloma added to her breast cancer. If we had not done biopsy, we would not have treated a disease that untreated is lethal in a much shorter period of time than breast cancer would be. So always send pathology, even when you know the diagnosis. And one of the mottos is, if you don't know, always culture tumors, always biopsy infections. You will get surprises. In terms of the reason to do the workup, this is a patient of mine, presented complaining of predominantly back pain. You can see she has this very extensive disease with epidural extension. Yes, I could biopsy this, but boy, it's going to be a heck of a lot easier to biopsy this lesion in her thigh with a lot less risk. So you do want to do the tumor workup if they're neurologically intact, and in this particular case turned out to be a lymphoma. Finally, I'm going to talk about degenerative, quote, emergencies. There are actually very few emergencies in degenerative disease because the degenerative process is by and large slow. Central cord syndrome was mentioned. So patients with cervical spinal stenosis will often with trauma have an acute neurologic deterioration typified by more weakness in the upper extremities than the lower extremities, so-called central cord syndrome. There is still a lot of debate on timing in these patients. Most of these patients, if you leave them alone, will make some recovery and will eventually come to surgery. There is a growing movement. A lot of people do feel you're probably better off treating these people urgently, but not emergently. This is not something I would tend to do in the middle of the night, but these are patients that I tend to want to do early within the first day or two of presentation. But we really don't have great evidence for that, but there is some. And the last one I want to talk about is Cauda-Equina syndrome. Those of you who are dealing with emergency departments on a regular basis will constantly get referrals for Cauda-Equina syndrome. And if your ED is anything like every ED I've ever worked in, it's approximately 1% of the Cauda-Equina referrals are actually Cauda-Equina. Problem is that our colleagues who work in emergency departments are taught that any problems with bowel or bladder disturbance is Cauda-Equina syndrome. It's not. Cauda-Equina syndrome is urinary retention. If they have incontinence, they have incontinence because of overflow. It's actually fairly easy to determine this if you bring a patient in and they have incontinence, or if they have retention, do an ultrasound bladder scan, post-void residual. If they have urinary retention, then you have to worry about Cauda-Equina syndrome. If they have a completely empty bladder, they do not have Cauda-Equina syndrome. If you're suspecting Cauda-Equina syndrome, you need MRI as the test of preference. If they can't get an MRI, a CT myelogram. And as a simple rule, if you see CSF on every cut, they do not have Cauda-Equina syndrome. You have to have complete occlusion of the canal to have Cauda-Equina syndrome. And that's a quick overview of the emergency assessment of spinal patients. A complete and accurate assessment in the emergency department. The goal is to assess the presence of and how to prevent neurologic damage. In trauma, the stability assessment is vital, and you'll get a little bit more on later, but in terms of what are stable and unstable injuries. History, incredibly important in all of these pathologies. In trauma, the key is what was the level of violence that spine was submitted to. That's going to tell you what their risks are. You must examine the patient. And again, in the trauma patient, you gotta roll them over and see what's going on in the back. Yep. And again, CT is the mainstay of assessment in trauma. MRI is the mainstay in infection and tumor. Thank you.